Welcome to Biophysics of Ablation. The topic that seemed to be boring, but this is the place where biology, physiology meets the physics. The knowledge of the basic science is necessary to perform efficient and safe ablations. In every EP lab nowadays, we have plenty of different screens full of colorful images. Today, we put some more attention to radiofrequency generator panel with power and temperature setting, impedance and temperature readings. The most frequent source of energy ablation is radiofrequency current. During this presentation, we'll focus on this ablation technique. Today, we'll skip cryoballoon part as we are limited by the time of presentation. Radiofrequency is defined as frequency above 10 kHz. In EP lab, we use frequencies around 500 kHz. The advantage of this frequency is lack of electrolytic effect and no nerves or cardiac tissue stimulation. During a ref current delivery, we closed a circuit consisted of generator, catheter, indifferent electrode, and patient's body. The highest current density is under the tip of the ablation catheter. Thanks to this phenomenon, the tissue damage occurs in the region. But if you use silicon multi-use dispersive electrode, be sure that there is a perfect contact with patient's body, just to avoid second high current density region on the skin. There are present case reports showing skin burns in case of bad dispersive electrode to skin contact, as there are two regions of ablation, the second one on the patient's back. Another slide explains the role of good catheter tip tissue contact. The current density decreases within few millimeters distance, and energy delivery becomes ineffective. That means that if we want to achieve durable lesion, we need to stay in a good contact with the tissue. Another important issue is that we need to influence the tissue with the current flow, not with the hot tip of the catheter. The main tissue damage occurs in catheter contact zone. The current flow heats the tissue in resistive heating zone. The heat from this region spreads through the tissue and ablates the tissue in conductive heating zone. Temperature conduction results in RF ablation latency. This means that when we stop energy delivery, the tissue is still influenced by energy that spreads through a conductive heating zone. It is extremely important in case of slow pathway ablation, because when you ablate in slow pathway region and you observe junctional beats or rhythm, you have to stop ablation immediately after first junctional beat being not conducted to the ventricles. In other case, if you want to stop the energy delivery, the thermal latency may lead to complete AV block. This nicely explains the reason why you need one more person in front of the screen of EP system, because you both are responsible for this observation. Both ablation strategies, cryoballoon and radiofrequency ablation, critically depend on contact with the tissue. On this slide, you can see the list of factors affecting lesion formation with radiofrequency ablation. The list starts with tissue contact force as a main and most important factor influencing the lesion creation. tissue temperature achieved and power delivered are also extremely important. The application time is less important until we reach temperature and the power is delivered efficiently. In case of conventional RF ablation catheters, you must be aware of cavitary blood flow and its cooling effect in high flow regions like atrioventricular valve rings. This is observed, this is important in case of accessory pathway ablation. In such a case, you will need more energy to achieve desired temperature. It's because the blood flow cools down the tip of the catheter. It is also important to know that the tip-to-tissue orientation and the catheter construction with temperature sense and location, because it is crucial for interpretation of displayed ablation parameters. In other words, remember, you must know how the tools you are using work and how they are constructed. The impedance is one of the parameters that are very often undervalued. This is an example of a study with cooled tip catheters in a power control mode and base impedance influence on ablation results. Unfortunately, it is quite common that operators do not know the impedance value during EP procedure or do not observe the change in its values. As most of the ablations are performed with power-controlled cooled tip catheters today, it is crucial to be aware of impedance, because the same power may be achieved with different current value depending on impedance according to the equation. The body impedance is something we cannot change, but we can reduce impedance in the circuit with different dispersive electrode location. These diagrams showed the impact of initial impedance on width, depth, and energy penetration region and its correlation of impedance drop and ablation lesion size. There you can see two different situations with different initial impedance, 100 ohms and 200 ohms, like you can observe in the CS region or adult vessels. The impedance drop was similar, but the total amount of energy was different and the lesion size was smaller. So please remember to optimize not only the quality of signals, but also the base impedance. This is also important to observe not only base impedance, but also the change, the percentage change. There is another important issue regarding the impedance. When you observe impedance curve on your EP system or just the values during radiofrequency application, the impedance drop around 10 to 15% of base impedance indicates proper and safe energy delivery. If the impedance drops more than 15%, it may be a predictor of overheating the tissue and may result in steam pop. On the other hand, if the impedance drops less than 10%, it may be a result of poor catheter-to-tissue contact. As I mentioned before, the lesion size is determined by the amount of energy that is delivered to the tissue. We must be aware that most of the energy is lost in the blood circuit. That means that radiofrequency applications with very low power settings are not efficient as most of this energy is lost. The higher the tissue temperature is reached, the larger the lesion size is achieved. And this phenomenon does not depend on the ablation mode. And now let's talk about ablation modes, with a special focus on standard non-irrigated catheters. In general, there are two ablation modes, the power control and temperature controlled ablation. It is important to be aware of ablation mode used during energy delivery. In a power controlled mode, the power that will be delivered is preset. The power is delivered, the more power is delivered, the larger lesion is created. In the power controlled mode, the temperature cutoff limit is set for the safety reason. In fact, the temperature is not controlled in this mode. The generator delivers preset power as long as the temperature limit is not reached, and the tip temperature correlates positively with lesion size. In this ablation mode, the fixed power is being delivered with gradual temperature increase. If the temperature limit is reached, ablation will be interrupted immediately. It is important to observe the impedance behavior during ablation. If the impedance drop is less than 10%, it indicates that lesion formation is ineffective. If it's more than 15%, be careful and manipulate the catheter with caution, because this may lead to overheating and steam pop. The second ablation mode, the temperature-controlled ablation. In this mode, desired tip temperature is preset. In this ablation mode, we have more control on what we are doing. Because the generator delivers as much power as it is needed to obtain proper tip, means tissue temperature, the amount of power is regulated to maintain the temperature, but the safety limit is set to avoid dangerous amount power output in case the temperature is too low. In temperature-controlled mode, some RF generators deliver extra power at the beginning of ablation to reach desired temperature quicker. This is why you should start with lower energy setting when you ablate close to the structures you don't want to damage. For example, slow pathway, and eventually titrate power to reach desired temperature. Remember that when you start with 40 watts, you may not be able to react on first block junctional bleed, and you may end up the procedure with complete AV block. The temperature readings from the tip of the catheter indicates temperature 10 to 30 degrees less than 2 to 3 millimeters under the tissue surface. And there you can see the summary of both ablation modes. In power control mode, fixed power value and temperature rise to the limit if reached. And temperature control mode, power titration to maintain and not to exceed desired temperature setting. Catheter to tissue contact. Another important parameter influencing safety and efficiency of RF ablation. The higher the contact force, the deeper penetration of energy is achieved. The same fixed power with higher contact force creates larger lesion. And because of that, it seems to be reasonable to titrate energy to avoid overheating the tissue and to avoid steam pop tissue damage. In case of steam pop occurs. This slide presents steam pop on turkey breast with deep catheter penetration into the tissue. But in real life, when steam pop occurs, please observe the impedance behavior. If the impedance rises during steam pop and does not return to normal values, it may indicate that your catheter stays in pericardial space due to transmural rupture. If impedance will rise and return to initial values, it usually means that you are still on endocardial side. Anyway, the steam pop may create crater-like thrombogenic region. Of course, the cavity where steam pop occurs really matter. In the atrium, it is more likely that it results in perforation, while in the ventricle, steam pop usually keeps the wall continuous. Char and thrombus formation is another phenomenon that may occur during the ablation. It is another reason of impedance observation, especially with non-irrigated catheter ablation. The impedance rise and high temperature with low power values indicate that there is possible charring on the tip of the catheter, and it should lead to catheter removal and tip inspection. In our EP lab, in temperature controlled mode, the temperature limit is 55 centigrades. This value is a result of experimental studies, where above 55 centigrades there was a significant increase in thrombus formation rates. That is why during slow pathway ablation our default setting is 55 centigrades and the power titration is starting from 25 to 30 watts. It's safer to add watts and observe the results. Cool or irrigated tip catheters. What for? The answer is to avoid overheating of the tip of the catheter and thus maintain the possibility of higher power delivery without risk of thrombus formation. This is a combination of possibilities of large tip catheters and ability to deliver high power, and the combination with small tip catheter mapping resolution and flexibility. In summary, comparing 4 mm conventional catheter to cool tip catheter with cooling, we achieve the ability of thrombus and char formation, risk reduction, and higher power delivery. Of course, under 4 mm, we lose the control, so that's the lower limit of the tip of the catheter size. Another parameter, the lesion size, the lesion shape. When we use conventional catheters, the largest diameter of lesion is on the tissue surface. In case we use cool tip catheter, the largest diameter is located under the surface, and thus, when we plan continuous line, we should take this into consideration. And now, some comparison of conventional and irrigated ablation. With conventional ablation, usually temperature control is used. The RF generator controls the power to reach and maintain target temperature. In irrigated ablation, with catheters with temperature sensor located in cooled space inside the tip, we use power control mode. The temperature reading is only an approximation, and its value is limited to safety cutoff. In general, in this mode, radiofrequency generator delivers fixed power. Sometimes it is described as power control with temperature control, but this is misleading and should be avoided. We should remember that temperature reading on most of irrigated catheters does not reflect real tissue temperature. Thus, while we see safe temperature values of 32 to 33 centigrades, it does not guarantee that we are not overheating the tissue. Again, in case of irrigated catheter ablation, the highest temperature is obtained deeper within the tissue than during conventional ablation. Another important topic is irrigation rate flow. The recommended irrigation speed should be followed because when it is decreased, the risk of thrombus or char formation is higher than during regular flow. Thus, it should not be reduced. On the other side, when irrigation flow is increased above recommended value, the superficial diameter of ablation lesion is reduced. It is because with increased irrigation, some part of the energy is eliminated on superficial regions, and that may lead to creation of edema and temporarily continuous ablation line, which within next hours or days result in a reconnection between isolated regions. So now, as we are aware of all these situations, all these tips and tricks and the phenomena occurring during the ablation, there is a strong advice. Before you start ablation, study catheter characteristics and construction, because there are some small technical differences resulting in different parameter readings. In some of the catheters, tissue overheating occurs during 2 to 3 centigrades deep temperature rise, while in others the temperature is fixed unless there is obstruction in silent flow. That is why, while using power control mode and cool tip catheters, the operator should observe all other signs and symptoms of tissue overheating. In a summary, every physician performing ablation must know biophysics of ablation. Before attempting procedure, every electrophysiologist needs to know how the generator works, how the catheter is constructed, and how to properly set power and temperature, and finally, how to interpret displayed parameters. Thank you for your attention.